David, we were talking about this young woman with chronic pancreatitis who had one episode of acute pancreatitis, who didn't drink but did smoke, and who had her gallbladder removed in an attempt to prevent the development of recurrent pancreatitis or chronic pancreatitis. And it makes me wonder a little bit about, are we sure in that individual patient or in any patient what the etiology is, or what are the types of etiologies that we should consider in that patient and in all patients, and how do we frame those etiologies?
Right, so that's an important point. And talking a little bit more about the etiologies, we established that chronic pancreatitis is a syndrome, which is a group of signs and symptoms that occur together and define a pathologic condition. What we would like to know is where it's coming from and where it's going. And what we have learned over the last 15 or 20 years, that chronic pancreatitis is not only caused by alcohol, like I was taught when I was in medical school. There are actually a variety of things that can cause pancreatitis. And we've been working for the last 12 or 13 years to really define what people with chronic pancreatitis actually have as potential etiologies. So we've learned from studies on hereditary pancreatitis that mutations in the trypsin gene can cause trypsin to be prematurely activated and trigger acute pancreatitis, which eventually leads to chronic pancreatitis. That's a very important observation, not because hereditary pancreatitis is so common, but it sort of tells us that acute pancreatitis starts a process that can eventually lead to chronic pancreatitis. And what is the process, what's driving the process, and how do these factors mix in? So you've mentioned that this girl does not drink alcohol. When I was trained, I was asked to have psychiatrists get a confession out of her, but she would have probably come up as innocent from the alcohol, we would think. But based on what you've seen from her, what type of etiologies that you've become familiar with do you think that she may be suffering from?
Well, in the past, I probably would have labeled her as idiopathic, and I think that's before we began to understand that there's more than just alcohol in the environment that can create toxicity in the gland. And certainly I think the data that's come from many parts of the world now, including the studies from you, have documented how important smoking is in these patients. And I think if you consider alcohol and tobacco as not the only toxins that can do this, and certainly not the only mechanism that leads to injury, they are modifiable. So they're very important to know about. And I think the data on smoking now is not only for chronic pancreatitis, it accelerates the course of disease. It increases the risk of getting pancreatic cancer. It increases the risk of getting the disease in the first place, but it also increases the risk of even having an episode of acute pancreatitis. And so it's a toxin that I think has been vastly underappreciated, and again, which is modifiable. I don't, this is a young lady who had a gallbladder removed in the assumption that it might have been some form of gallstone disease. It's certainly possible that patients with one episode of severe pancreatitis will start the process, and that episode of severe will be enough to drive it to chronic pancreatitis. So maybe that could be playing a role in this lady, but I didn't do genetic testing. So is it possible that she has a number of mutations, one or more mutations that underlie this?
That's possible, and we're still beginning to sort that out. I think what has happened over the last decade that is notable is that several groups around the world have really done studies that are large enough to be able to sort out the difference between patients who drink and don't smoke and don't drink, and drink a little bit and smoke a lot, or drink a lot and smoke a little bit. And what they have revealed, and there was actually 3 studies that came out in 2009 that showed that alcohol by itself is actually a very low risk factor for pancreatitis. Boy, was that a shock. And in our study of 1,000 patients in the NAPS2 study, only about 15% could chronic pancreatitis be attributed to heavy alcohol alone. smoking turned out to be a stronger risk factor than even alcohol. And this was an idea that was originally brought up by the Italians, and then we've been able to look at that carefully, and that's the case. What's most important, though, is that both alcohol and smoking together are synergistic and have a multiplying effect. So trying to be able to address those etiologic factors that you can change is very important. We looked, as I mentioned, at 1,000 patients with pancreatitis. And when we designed the study, we put together a system that we called TIGER-O, which is an acronym for toxic causes, idiopathic, the genetic, autoimmune, severe acute pancreatitis, as we mentioned, the recurrent acute and severe, and obstructive, which is a little bit different. You mentioned that some patients can have a very severe episode of acute pancreatitis and have 90% pancreatic necrosis, and they end up with chronic pancreatitis. The idiopathic, we don't know what causes those, but genetic is beginning to emerge as a very important etiology. How often do you think about genetic causes in the patients that you see?
Well, it's a challenging question. As I've been fascinated in recent studies that have tried to determine the relative preponderance of different etiologies, and as more and more modern studies are done, idiopathic sort of begins to rise to the top of causes,
right,
replacing the things that we used to think about. I know my patients are happy about that, so they're not automatically accused of being alcoholics when they first arrive in clinic. But I'm always struck by the idea that these genetic mutations, or the genetic mutations we know about, or additional mutations, may be present in most of our patients. They may set the stage in various ways for disease in some of our patients. The percentages are, I think are a little bit unclear right now. So I envision a time in the future where I'm going to be much more interested in doing genetic testing to predict the future, to predict what's going to happen in these patients. Right now, I do it in patients in whom I can't come up with an easy alternative solution. But it is sometimes challenging to convince patients to have genetic testing. Some patients are interested, some patients are afraid of it in terms of insurance repercussions or future developments that might have a negative impact on their ability to get health insurance. So I do it in still, I think, a minority of patients, and in a select group where I have convinced myself that there's no other obvious alternative.
Right. Well, this is an emerging area, and we certainly have a number of people that have contacted us because they did genetic testing and they can't interpret the results. What we're finding is more and more mutations, but they're clustering in either acinar cells or duct cells. And so what began to be a very complex series of mutations and interactions is beginning to collapse into etiologies that are acinar cell-based or duct cell-based. And thinking of it very simply, the acinar cells, it's all about hypersensitivity to external stimuli and linked with calcium and trypsin. The duct is very interesting as well because the cystic fibrosis gene, there are mutations that only affect the pancreas, the male reproductive organ, and the sinus, and those individuals have a problem with generating enough pressure inside of the pancreatic duct to flush out the pancreatic enzymes. That goes in concert with distal obstruction or main duct obstruction, where you have distal resistance. So if you either have a problem with distal resistance or head pressure to push the digestive enzymes out, that puts you at risk. So those are very interesting combinations, and what used to be complicated is very simple. There was just a paper published in January, and I'm sorry I was not part of it, that really showed that a significant portion of patients with pancreatic divisum and pancreatitis have CFTR mutations. And now what we're learning is how to put the pieces together so when you get your genetic results, you can put the pieces in a way that you can figure out, is it a duct problem, is it an acinar cell problem, is it an obstruction problem, is it an autoimmune problem? And now we can start targeting the etiology of the disease rather than just the symptoms and trying to replace lost function like loss of exocrine enzymes with pancreatic enzyme replacement or replacement of loss of beta cells with insulin therapy and treating the pain. So the etiologies turn out to be important because now we can target the patients early and we can give them problem-specific treatments and perhaps prevent the progression of diseases that are irreversible when they get to a later stage.
And you made a very fascinating observation, which I just want to reinforce as we close this session. And that is, you spoke about etiologies as this, or this, or this, or this. But it seems like in the future we're going to speak about etiologies as this, and this, and this. So it's going to be an accumulation of etiologies that together produce disease in an individual patient.
Right. So that's the whole area of modeling and simulation, where we do a representation of a disease and then simulate what happens under different conditions so we can figure out what exactly is going on in an individual patient and determine what kind of therapy is most likely going to be of benefit to that patient.